here tonight. I practice palliative medicine here at Duke. And a few weeks ago, I was asked to see a patient in the emergency room of one of our hospitals. The patient, who I will call Mr. Roberts, had advanced dementia. He had not spoken in more than 3 years. He was brought to the hospital by his brother and niece, who for several years had cared for Mr. Roberts in the brother's home. An initial evaluation by the emergency physicians made clear that Mr. Roberts had a large pneumonia and was beginning to suffer septic shock and respiratory failure. After a brief conversation with his family members, they agreed with my proposal that we give him antibiotics, oxygen, and other supportive therapy, but that we forego putting him on a breathing machine, even if he came to the point of not being able to breathe on his own. I then asked his brother and niece if they had ever considered hospice care for Mr. Roberts. Both shook their heads adamantly and said, "We are not interested in hospice." "Why is that?" I asked. They responded as I have heard numerous others respond here in Durham and on the south side of Chicago, where I practiced palliative medicine for several years. They described their impression that hospice too often forgoes any effort to provide medical care for patients, instead focusing only on giving potent drugs like morphine and sedatives, and thereby hastening patients' death. I begin with this story because it points to a question I ask you to consider tonight. With respect to the question of assisted suicide, which of the following should physicians care about most? 1, maintaining the trust of those who, like Mr. Roberts and his family, are already experiencing the debility, dependence, and suffering that advanced illness brings. Or 2, empowering those who, like Brittany Maynard, who Jeff mentioned, seek through assisted suicide to avoid such debility, dependence, and suffering. Which solidarity is most important for physicians, as physicians? Brittany Maynard, as Jeff said, was diagnosed with a brain cancer and November 1st, 2014, following a plan she had specified publicly in advance. She died after ingesting a lethal cocktail of drugs prescribed by her physician in Oregon. And her story illustrates a pattern, which is that those who seek assisted suicide are rarely driven by the direct experience of refractory pain or other symptoms. Or that is to say, at least, this is not the primary motivation for assisted suicide. At the time she committed suicide, Ms. Maynard was not experiencing symptoms beyond the reach of conventional palliative medicine, nor were such symptoms expected with a brain tumor of the type she suffered. Rather, as she herself said, she chose to enter life on her own terms in order to avoid the prospect of further debility and decline and diminishment, in which she might, in her terms, quote, suffer personality changes and verbal, cognitive, and motor loss of virtually any kind, end quote. Ms. Maynard's desire to avoid debility and dependence reflects the pattern found in official reports from Oregon and Washington State, where 9 out of 10 patients requesting assisted suicide have reported being concerned about losing autonomy and being less able to engage in activities making life enjoyable. So this is important to note. The problem to which assisted suicide poses or is posed as a solution is not uncontrolled pain or breathlessness or other such symptoms. In Oregon, only 1 in 4 patients has reported even concern about inadequate pain control in the future, much less inadequate pain control at the time. And at no time in history have physicians like Dr. Quill and myself and patients had greater access to effective tools for treating pain and other distressing symptoms. Tools which can be deployed aggressively under ethical norms that have guided medicine for ages. The problem to which assisted suicide poses a solution is the problem of the loss of control, the loss of self-determination and autonomy in the face of debilitating illness. In a recent piece, the one that Jeff mentioned in the Journal of the American Medical Association, Dr. Quill and colleagues wrote, quote, "Patients with serious illness wish to have control over their own bodies, their own lives, and concern about future physical and psychosocial distress." And Ms. Maynard put the point bluntly in her online manifesto. "I want to die on my own terms," she wrote. She then added a question. "My question is, who has the right to tell me that I don't deserve this choice?" That is a powerful question in our day. The question of choice, and who could possibly have the right to keep from someone a choice? It's interesting that the former Hemlock Society is now called Compassion and Choices, a substantial improvement in political posture. The California law legalizing assisted suicide was called the End of Life Options Act. When Governor Jerry Brown signed it, he said he did not know if he would avail himself of assisted suicide if he faced the prospect of severe decline. But, quote, "I wouldn't deny that right to others," end quote. So choice looms large, and it certainly has to be taken seriously. But what kind of a choice is Ms. Maynard and others like her being denied if physicians refuse to participate in assisted suicide? Ms. Maynard already had the right to refuse life-sustaining treatment. She had the right to proportionate palliation of her symptoms, even if death were hastened as a side effect. She had the liberty to cause her death by numerous methods which do not involve physicians, and which are equally, if not more, efficient and effective than ingesting an overdose of pharmaceuticals. So why is it so essential that she and others have physicians, in particular, cooperate in helping them to kill themselves? That physicians are being asked to cooperate shows that the right to choose is, as the late Robert Burt noted, radically incomplete as a justification for physician-assisted suicide. The confident assertion of the self-determination right, Dr. Burt wrote, leaves unacknowledged and unanswered a crucial background question: who can be trusted to care for me when I'm too vulnerable and fearful to care for myself? That was not a rhetorical question for Mr. Roberts' family and many others. Indeed, they, like I think too many others, have come to the conclusion that some physicians who wield the tools of palliative medicine are not to be trusted, because such physicians have so prioritized relieving suffering that they fail to do what the patients count on physicians to do: to use reasonable means to preserve the health and life of the patient. How much less would Mr. Roberts' family entrust him to a physician or a group of physicians that is in the habit of practicing assisted suicide? It is hard to imagine their worries will be assuaged by hearing that the physicians only engage in such practices for those who choose them. So herein lies the rub. Physicians cannot practice causing the death of their patients without undermining the trust on which the practice of medicine depends. This is not a new insight. Physicians who care for patients with advanced illness have long known that both they and their patients will at times be tempted to do away with suffering by doing away with the patient. To mitigate against that temptation, physicians have, for more than 2 millennia, have sworn different versions of the Hippocratic Oath, including its foremost proscription: "I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect." The American Medical Association has maintained since its founding that physician-assisted suicide is fundamentally inconsistent with the physician's professional role. The World Medical Association, since it was founded just after the Second World War in response to some of the tragic misuses of medicine, has consistently opposed assisted suicide in euthanasia. Indeed, insofar as physicians enjoy the trust of patients made vulnerable by illness, I propose that it is because patients can count on them to maintain solidarity with those who are sick and disabled, seeking only to heal and refusing to use their skills and powers to do harm. That is why physicians have refused to participate in capital punishment. It's why physicians refuse to be active combatants in war, and it's why they refuse to help patients commit suicide. Now, importantly, this boundary against intentionally causing the patient's death not only gives patients a reason to trust physicians, but it also gives physicians the freedom that they need, that we need, to do our work. For example, I was able to tell Mr. Roberts' family members that as a physician, I am committed to never intentionally hastening or causing a patient's death. That boundary creates a space in which I and other physicians can act decisively to palliate distressing symptoms. For example, in this case, using morphine to alleviate the apparent breathlessness that Mr. Roberts was experiencing. Without this boundary, Mr. Roberts' family would have good reason to worry that the morphine that leads to sedation is dosed not in proportion to the pain or the breathlessness, but in an effort to hurry the dying process along. I'll close by returning